Hello, my name's J.O. Welcome to the Maximize Your Medicare YouTube channel. Today's video, I'm going to be discussing Medigap's Plan G, and comparing it to the very popular Plan N. Just as a quick note, this is something about me. I'm a certified financial planner. You can see my quotes online in a variety of news places, in media outlets around the internet, TV, radio. My book's probably at your local library. You can find out all the information on the official book website, www.maximizeyourmedicare.com. There are a number of other places to get information from me. YouTube, of course, this channel. There's also a podcast, a newsletter, and on the book website, you can pose your private questions to me. Your first answer is free. I'm not going to charge you for services under GH2 benefits unless very complicated. I would always tell you in advance. So let's just get right into it today. This is about Medigap. So for newcomers to Medicare, so the original federal Medicare card, right, can be thought of as a very good chassis to a car. That said, as you may know, it doesn't cover everything. There are two primary ways that people cover the things that the original federal card doesn't. One is called Medicare Advantage. One is called Medigap. And we will deal with Medicare Advantage and how to use the Medicare.gov site to figure out what might be best for you. But today what we're going to address is Medigap. And you can see this grid, which is copied from Maximize Your Medicare, right? And the main points there are over there to your left, which is that this grid is standardized, meaning that I didn't need to create this grid from a particular carrier to explain what Plan N or Plan G were. They are identical at both carriers. No matter what carrier you go to, Plan N is the same at carrier 1 as it is a carrier 5. It must be. Now on part of the grid here is I still have column F showing up. The reality is that for newcomers to Medicare, this is no longer available for sale. It is available, however, for persons who have both Part A and Part B coverage dates prior to January 1st, 2020. And you can see a prior video where I actually discussed why this still may be a viable option for them. Now, a couple of things about the Medicare and the Medigap market, if you will, the actual competitive market. One is this is a very highly competitive. Highly competitive. In other words, if you're turning 65, when I check out for clients in location number 1 versus location number 3, I'm very easily able to locate multiple carriers within $10 a month, and not just one, not just two. And this is a source of comfort for consumers, of course, because it is this tightly competitive. And that's going to matter as I get to other slides during this video. Other outstanding things about Medigap. No network, meaning that if your healthcare provider, hospital, doctor, durable medical equipment store, if they accept the federal Medicare card, they will accept your Medigap card. No problem. And this is a source of some comfort because some people are uncomfortable with networks. Now, I've also dealt with the fact that under Medicare, depending on your location, that the hurdle of networks may not be as great as perceived. We'll move on. That's for a later date. So the question here is, can your rates increase? So yes, a very highly competitive rate at the beginning. Can your rate increase? Yes, the answer is yes, but it's very important to know that it's not going to be based on your individual claims. That will not matter. What will matter is the collective risk of your fellow policyholders. Okay? It's not your individual claim. And of course, one of the last and very, very good things here about Medigap is the only one that can cancel is you. Meaning that once you have a Medigap card, the only person who can decide to cancel is you, as long as you continue to pay your premium. When I compare Plan G and Plan N, they do look quite similar. And you can see the comparison there on the two columns. Plan G, you're responsible for the Part B deductible. In 2020, that's $198. It's reset annually by the federal government. Under Plan G, once you satisfy the Part B deductible, then Medicare and Medigap combine and they pay the entire balance, meaning that your out-of-pocket costs under Medigap after you've satisfied the Part B deductible is zero across the board. Now, Plan N is similar in many respects, but it has a few differences, and let's just go through what happens under Plan N. Under Plan N, much like Plan G, you are responsible for the Part B deductible, the $198 I just mentioned. In addition to that, you may be responsible for office copays. Office copays, and what's not on this slide is also you can be charged a copay for an emergency room visit. So we're going to go through an example later in the video about how to think through how many times you go to the doctor. And when maybe you're one of those persons who never goes to the doctor. It is possible that answer is zero. It can also be up to $20. And finally, the third point here on the right-hand column under Plan N, unlike Plan G, you are responsible for Part B excess charges. We'll get into my explanation about what Part B excess charges are and what the real financial impact could be. The one getting most of the headlines, the fact of what goes on in most, as the one that gets the headlines, of course, is price, the premium. Plan N, no question, is less expensive than Plan G. This gives you a good idea about what the approximate prices really look like today. As of today, let's call it June 2020. Okay. And you'll see that in most states in the country, you can find approximately $90 area. That is a good approximation for Plan N for a female who's turning 65 in most of the United States. And of course, that's a very attractive price because when you add up Plan N plus Medicare Part B and then a standalone prescription plan, I've given you a ballpark figure, $267 odd. Now, if you had to buy private insurance at 64.9 years old, there's no insurance at $267 unless you receive the subsidy, which is APTC under the Affordable Care Act. And even if you did find insurance that cost that price and you got the subsidy, the quality of coverage you would get under Medicare plus Medigap and a standalone prescription plan would be miles better. The deductibles are astronomically lower, right? Because at $270 for a 64-and-a-half-year-old, your deductible is $2,000. $2,000 and higher, $5,000, even up to the full amount of the out-of-pocket maximum. Under Medigap and Plan N, Medigap, Medicare, and Plan N, $198. Under Plan G, you can see it's more expensive than Plan N. And you can find Plan G in the $100 range. Now, I'm a broker. In other words, GH2 Benefits is a brokerage. Okay, so I'm not burdened. I'm not held hostage is the wrong word, isn't it? In other words, I get to pick and choose, cherry pick carrier based on quality and price. Okay. In other words, I get to compare prices across insurance carriers, and I'm agnostic, right? My job is to, as a fiduciary, is to find you the best coverage at a price that you can afford. And you can see those are the approximate prices for Plan G, and those are good in most parts of the country. And there can be wide exceptions, no question about that. There are notable exceptions. Florida, for its demographic reasons. New York, for a different set of reasons. Okay, but for many locations in the United States, those are the differences. And so you can see it. Plan N, almost always less expensive than Plan G. Now, I mentioned that Plan N doesn't cover the excess charge and Plan G does, and you can see it. Let's just flip back here real quickly. You can see it here. If you look down the column under Plan G, you can see Part B excess charges, and under Plan G, there's an X, and under Plan N, there is no X. And what this means, each of these X's means that is covered. Under Plan N, it isn't. So under Part B, healthcare provider is legally allowed to charge 15% more than the Medicare approved amount. Now, the Medicare approved amount can be thought of as a list of MSRPs. Joint replacement surgery in New York with an MSRP. Joint replacement surgery, the same joint replacement surgery in Iowa would have a notably different one, just due to cost of living. Anyway, what happens here is Plan G, you are not responsible for this. Why? Because it pays for the 20% that Part B doesn't cover. It also pays for all of the excess charge. Under Plan N, what happens is Plan N pays for the 20% of the Medicare approved amount. It pays 0 of the Part B excess charge. And there's your simple example there on the right, which is, let's just pretend, for example, in some location, let's call it Iowa, that the joint replacement surgery Medicare approved amount is $30,000. Okay, in this particular case, under Plan N, you would have 0 if, in fact, the doctor charged $30,000 under Part B. Let's just say you went to his outpatient clinic and that's the charge you got. Under Part B excess rules, the doctor could have charged you up to $4,500 in Part B excess. That's legal. Okay. Under Plan G, that entire excess is paid by the Medigap plan. Under Plan N, you're responsible. Now, use extreme examples because it's just to illustrate my point. Okay. Can there be an excess charge of $10? Yes, there can be. I've seen it. I've seen it in cases where something happened, like even on a routine appointment to a podiatrist where foot cleanings had to be done for a diabetic. That can happen. Nevertheless, I get told, Jay, this doesn't happen. This kind of, I never see the Part B excess charge. What are you talking about? And let's just go through this here and let's just go through the math of money. So in this hypothetical here, you can see that I've got a typo. Crap. So now let's take a look at how the math actually works. And this is a real life example of a female turning 65. You can find a Plan G, approximately $110, $115 a month. Plan N, $90. As you can see there, under Plan G, once you meet the Part B deductible, there are no other charges for healthcare services. For Plan N, you pay the $90. You also have to pay the $198, which is the Part B deductible. In addition to that, you've got office visits up to $20 a visit. Now, some doctors don't charge the full $20, and emergency room visits are $50 a copay. So you can see originally that there's a $20 premium advantage to Plan N. On the right-hand column, what you see is that can start to erode. So you go to the doctor's 4 office visits in a year, let's just say, call it. And if you divide through by 12, what I've done here is I'm trying to equate the two on a monthly average basis. So 80 divided by 12, 667. One emergency room every 2 years is $50 once, right? So if you do divide that by 24 or $25 a year, what you get is $2.08. So what was a $20 advantage is now lower by $8.73, which is $6.67 plus $2.08. And now the difference is not $20, but it's actually $11.27. And under Plan N, you're still exposed to the Part B excess that I just explained. Now let's just talk about the Part B excess and what people don't consider, because very frequently what people say is, Jay, I never see what this excess charge is. The reality is I have seen it, and you can see it even in the simple example I said just before the break. But in addition to that, there are systematic reasons that the Part B excess can be applied, not even if not today, can be so in the future. And I'm just going to review a few of them. Number one, there is demographic and fiscal pressure on the Medicare system. Every year you hear the Medicare system's going bankrupt, Social Security is going bankrupt. First of all, let me just say, you can see me shaking my head vigorously. I don't see that happening, right? Because the government can certainly just mandate, government fiat can just create extra budget to go into those. So I'm not in that camp. That doesn't mean, however, that they're not trying to watch their P's and Q's. And if someone appointed me Medicare czar, fastest overall way, lower payment rates to hospitals, lower payment rates to doctors. Sorry. The demographic reality is there are 60 million people on the federal Medicare card, right? And in addition to that, one of the two presidential candidates is going to be proposing that the Medicare eligibility rate no longer be 65, but be lowered down to 60. It's not only the Medicare system itself, it's also pressure felt at the doctor. And I just ask you the hypothetical question: who wants to be a primary care physician in small town America? Right? Because the reality is, the private reality to the doctor is that person is very likely to have multiple hundreds of thousands of dollars of educational debt. It's so extreme, in fact, that some of you may not know, but in banks, there is such a thing as physician's mortgage. Meaning that, we need doctors. We all know that. We can accept that. But if you went to a bank and you showed them just pure mathematics, they would probably say no to a mortgage loan. So there are certain special groups of mortgages. One's called physician mortgages. And it's just to illustrate the tremendous pressure that big stakeholders, and not unimportant ones, are facing systematic pressure. These can create pressure on you, because then they could be pressurized to charge you the Part B excess. And people might say, well, Jay, that's very distasteful. The physician is being, greedy, et cetera, et cetera. And then I usually just try to pose you the following question, which is that your granddaughter or grandson, newly minted physician, worked all that time, mid-30s, until really being able to get any money to pay back their educational debt, and they get to legally charge the Part B excess. What do you tell them to do? I'll leave that with you to decide. There are a couple of other things here that people don't consider. Number one is the pressure on hospitals. Okay. So you can understand, and you may have seen this or know this or not, which is that the payment rates from the Medicare system to hospitals is lower under Medicare than it is under your individual health plan. It's lower than certainly under the group health plan. Okay. And that's for inpatient care, clearly under Part A, which is covered by Part A. So what you see is certain procedures being moved and called outpatient, covered by Part B. You can see hospital labels as clinics, outpatient clinic, under the hospital name. Why? Because those services are Part B covered services. Well, all of those services now are subject to the Part B excess. Last point, and it's just one of common sense, practical reality, which is really what Maximize Your Medicare is about, right? The rules, et cetera, et cetera. But then really what I'm trying to do, my entire objective here is just put on your common sense hat and think through and not be intimidated by these clauses, network, copay, deductible, open enrollment period, annual election period. That's the jargon. But just think to yourself practically here. If that thing had no value, right? In other words, let's just take a look at this box. If the box of Part B excess charges really had no value whatsoever, then wouldn't the hyper-competitive competitors charge you a penny? They don't. There's no carrier that even if you went through my math, and estimated something like $11.27 difference, they don't charge you $11.30 more for Plan G versus Plan N. They charge you more than that. Why is that? Because they know that the chance of Part B excess exists, and not only exists today, but exists in the future. Because if the probability of that was zero, they would charge zero. And why would they charge zero? Because then they would be more competitive in a hyper-competitive world. Let's just move away from insurance and financial contracts. Let's just call it two hammers in a hardware store. If one had a feature that was absolutely useless, the feature would either be go away, or the ability to charge for that extra feature would be zero. It's not. Let's just leave it with you there. So when can Plan N be better? And I'm not going to tell you, for example, that, it's not my job as broker, as, financial contract advisor here to say, okay, in every single instance on the planet, that Plan G is better due to the reasons that I suggested. There can be certain scenarios. Plan N, number one, the Part B charge can be outruled. It's not, there are certain states in the United States where you have rules at the state level imposed by the state government that don't allow Part B excess. Caveats there, of course, is that's today. No one said the rule can't be changed tomorrow. If the rule changed tomorrow in Minnesota, you don't get to call up the carriers in Minnesota and say, hey, they changed a rule. Can I change from Plan N to Plan G for no cost? The answer to that is no. you'd have to have medical underwriting. Okay. And there are very few states that do this, but it does exist, that very few states allow you to switch from Plan G to Plan N without medical underwriting. There can be very, very few exceptions. One of them, the state of New York. When else can Plan N be better? Well, I told you at the beginning that all Medigap plans have no network. And it can be that you need to save the $20. It can be. I'm not going to dispute that. It's not my job to tell you what to do with your money or how to value your money. Okay. But it can be that Medicare Advantage in your location can be inferior. And what do I mean by inferior? What I mean is there a lack of plans. The price of Medicare Advantage is high. The doctors in your area don't sign up to Medicare Advantage. That can happen in certain locations. When else? You could live in a very densely populated place, but it's almost impossible to figure out, meaning that your primary care physician, your specialist, your clinic and hospital belong to 4 different networks, as in network. That could be the case, right? So you can find that getting the right combination of providers and your network and the plan can be too difficult. That can happen. But let me just say that even in that instance, you can use Medicare Advantage PPOs, because one subtle point about Medicare, which is clearly superior to that of your individual plan prior to turning 65, is that that Medicare Advantage networks are going to be superior, and PPOs specifically, out of network simply means that they accept the federal Medicare card. So even if the specialist isn't in carrier number 1's Medicare Advantage plan, if that specialist accepts accepts the federal Medicare card, they simply are out of network. It can result in a higher cost of out-of-pocket for your, services that you receive from that specialist. But nevertheless, still be covered by your PPO. So you can see now that we kind of have a new reasoning, that Plan N, Plan G, okay, after I've gone through my slides here today in this video, what you see is, yes, you can see it that in certain cases for a carrier, it can be $30 a month. And then I've got this other question for you. And this is just practical reality. Again, this is not me. This is not me, excuse me. It is not me splitting atoms here. What it simply is look, if we need to save $30 a month at your household, if we need to save that premium difference, then isn't Medicare Advantage a viable alternative? Because instead of saving from 100, let's call it from 120 to 90 or 110 to 90, shouldn't we be trying to search for all the way down to 0 as your monthly premium, which does exist in most of the locations in the country? That's $1,000 of premium a year, okay? So in other words, if you're trying to save $240, why aren't we trying to save, $1,200? Just a rhetorical question. In addition to that is the second column there, which is that because I run a brokerage, because I have, information about multiple carriers, they're competing fiercely with each other. So what can happen is Plan N or one carrier 1 looks like this as your difference between Plan N and Plan G. Well, another one, however, could look like this. And now all of a sudden, the difference between Plan G and Plan N is just this. In other words, I've seen instances in certain parts of the country, and it will vary by location, that the difference between the two plans, $10, $12, $13 a month, ultimately across multiple carriers, not at the same carrier, but across multiple carriers. Okay, so now I'm comparing my Ford versus Toyota. Yeah, well, my Ford, price is like this, but my Toyota's price like this. Well, now I'm comparing this here. Okay, and so now you can see it when we took a look at this math here about how this works. That the entire difference can go away, meaning that it is possible to get the Part B excess charge coverage basically for free. Okay, that is entirely possible. And that, of course, leads to the obvious conclusion from my point of view, which is if I get this box and the coverage for basically zero, I don't give it away, right? We don't have to be talking about financial stuff, do we? Right? You don't give away free options. Rule number one of my financial advice that I can give in financial planning, right? Don't give away free options. If I can find the price, which will take work by me, but I do it all the time, to minimize the cost of this box that you do not see, but you now know can exist, I then, in those instances, I definitely would suggest to try to rethink whether or not that box is worth it. I'm going to wind it up here. Hopefully you've gotten something from today's video. Please be sure to subscribe to the rest of the videos by clicking the subscribe button at the bottom of your screen and be able to put your comments in the comment box. It helps other people discover the Maximize Your Medicare YouTube channel. Thanks for watching today's video. Be sure to subscribe to the Maximize Your Medicare channel, where you can find information about much more than Medicare.